Okay, we're up to the third part of Bearish Chapter 12, which is talking about the allergic response. We're talking about the perioperative allergic reaction. And remember that diagnosis is really required for acute treatment. This needs to be identified as soon as possible. Things you can do include sending labs, for example, a serum tryptase or histamine level, and then referring these patients to an allergist for further skin testing or RAST testing or ELISA screening. Now, if we have a patient who has known allergies, there are some considerations as we prepare our anesthetic plan and management for these patients. Of course, the first question is, did this patient actually have an allergic response, as they claim, or could it have been some sort of other adverse reaction or toxicity? So people will say they're allergic to morphine and it made them stop breathing, and we know that that's not really an allergic reaction. So known pharmacologic side effects are not allergic reactions. And similarly, any sort of predictable dose-related toxicity due to the route of administration or other coexisting conditions at the time of exposure, like patients who say that penicillin makes them throw up. Well, what was going on when they prescribed the penicillin? I was throwing up. And so all of these things need to be considered. On the other hand, remember that just because a patient has previously been exposed to a certain drug with no problem does not eliminate the possibility of developing anaphylaxis subsequently. And we always need to keep that information in the back of our minds. Now, any antigen out there could theoretically cause an allergic response in somebody. The most common causes classically were thought to be antibiotics, but any drug, including induction agents, muscle relaxants, NSAIDs, protamine, colloid expanders, or even blood products, can precipitate an allergic reaction. And some of the recent data I've checked say that the three most common causes are muscle relaxants, latex, and antibiotics. But many other drugs can cause anaphylaxis or other allergic reactions in the OR, and these would include bone cement, drug additives, insulin mannitol, methyl methacrylate cement, radiocontrast dye, and vitamin K. Now, patients who are administered neuromuscular blocking drugs may have an allergic reaction, and it's felt that more than 60% of intraoperative allergic reactions are due to these neuromuscular blocking agents. There may be some cross-reactivity with other neuromuscular blocking agents, and patients may become sensitized to the entire quaternary ammonium structure, which exists not only in neuromuscular blocking drugs, but in cosmetics, over-the-counter medications, and morphine. So these patients really need to be skin tested prior to anesthesia, and this involves taking a small sample of whatever drug it is you want to use and injecting it just under the dermis to see if there's an immune response. We want to distinguish these allergic reactions from any sort of non-immune histamine release, like as we see in atracurium or used to see in mivicurium. And so those are neuromuscular blocking agents. Propofol and barbiturates are actually pretty uncommon causes of allergic reaction. The same is true for opioids. Allergic reaction to those drugs is pretty rare. Remember, morphine can actually cause direct histamine release, but that's not really an allergic reaction. With local anesthetics, a true allergy is pretty rare. And we need to distinguish, did this patient have a true allergy with urticaria, with bronchoconstriction, with laryngeal edema? Could they have possibly had systemic toxicity, as we discussed last semester, with hypotension, neurologic symptoms? Maybe the patient had an intravascular injection and they are experiencing the epinephrine additive, causing increased heart rate and blood pressure and palpitations. Now, are patients more allergic to esters than to amides? And the answer is esters are metabolized to para-aminobenzoic acid, which is a pretty potent allergen. Now, we're taught that there's no cross-sensitivity between esters and amides. So if a patient is deathly allergic to an amide, it might still be reasonable to go ahead and give them an ester as part of their anesthetic management. But remember that even though the two drugs are structurally different, there are preservatives that are added to these drugs, and these preservatives can cause an allergic reaction. For example, methylparaben, which is totally safe, but it turns out it is metabolized to para-aminobenzoic acid. Also, sulfites like sodium bisulfite or metabosulfite can also act as allergens. In short, many people recommend that a preservative-free local anesthetic should be used in any patient who has a history of allergic reaction to local anesthetics. Patients who are given protamine are at risk for developing an allergic reaction. This is even more common in diabetic patients who have been exposed to NPH insulin, where the P stands for protamine, and so they have a prior exposure. Other patients who seem to be at increased risk for protamine allergy include patients with a seafood allergy and those who are post-vasectomy. Don't confuse the allergic response with other common responses to protamine, which include hypotension due to direct histamine release and pulmonary hypertension, probably due to complement activation. Penicillin is a very common perioperative allergy that we have to deal with. A true penicillin allergy is actually associated with a 3 to 4-fold increased risk of allergy to any drug. And our patients who have an allergy to penicillin had increased risk for allergy to cephalosporins. Well, this is very controversial, and especially because most penicillin allergies aren't even allergies in the first place. But we're going to analyze this just a little bit further. Let's notice over here, here's penicillin, and penicillin has several different side chains. And this is the side chain for penicillin over here. The side chain for ampicillin, which is pretty similar, and amoxicillin. Compare that with, say, the side chain for Keflex, cephalexin. It's very similar, and we might expect a strong crossover between penicillin and Keflex allergy. What about Kefsol, our favorite medicine in the operating room? Well, look what the side chain looks like over here. Instead, it's totally different. And in fact, cross-reactivity between Kefsol and penicillin is usually very low. Here's cefoxitin, and you can analyze each of the different drugs we give and determine how they compare to the penicillin or amoxicillin that the patient claims they are allergic to. This is just a table which shows the same thing. The drugs within the same column have similar molecular structures, and you can see Kefsol and cefoxitin are really living in their own little groups without a whole lot of crossover with other groups. So we've learned here that not all cephalosporins are the same. They don't all interact with penicillin, and in fact, even within the cephalosporins, for example, Kefsol or Ancef is not the same drug as Keflex. They are differently structured anatomically. It's probably safe to give cephalosporins, especially Kefsol, to patients who have a minor penicillin allergy, like rash or fever. But patients who have had anaphylaxis to penicillin probably should not get cephalosporins, just in case there's an issue. What about giving a test dose? Well, a pharmacologic test dose is very different from an immunologic test dose. An immunologic test dose involves many serial dilutions until you're giving 1,000th of the original dose or even less. And sometimes I'll do that just to make the surgeon happy, but usually we're just giving, let's say, 1 cc out of a 10 cc syringe, which is more than enough to precipitate a true immunologic reaction. Don't forget that latex is a very common culprit of perioperative allergic reaction. And people who have multiple exposures, like healthcare workers, as well as people who have spina bifida, urogenital abnormalities, as well as allergy to foods like bananas, avocado, or kiwi, these patients are all at risk for latex allergy. About 15% of anesthesiologists develop a latex allergy, which makes it an occupational hazard. And in fact, about 15% of the drug allergies that people experience during anesthesia could probably be attributed to a latex allergic reaction. Now, we said that most allergic reactions in the OR happen within 5 to 20 minutes after exposure to the drug, but with latex, the onset can be delayed by up to 30 minutes, which can make it harder to pinpoint the exact cause of the hypotension. Latex is found not only in rubber gloves but also in medical devices and in latex caps for drug vials. Here's a little article from the British Medical Journal in 1994 where a patient had a history of latex allergy with anaphylaxis. And it says 4 months later she developed wheezing and shortness of breath 30 minutes after her son directed the flow of air from a whoopee cushion at her face. She ended up getting adrenaline or epinephrine injection and had a less severe reaction, although she did have to go to the hospital. So we see that even a harmless whoopee cushion can precipitate anaphylactic reaction to latex rubber. So in patients who have a drug allergy, here's a chart that may help distinguish between that and drug toxicity, looking at mechanism, manifestations, predictability, previous exposure to the offending agent, whether the severity of the response is related to the dose of the drug given, the onset time frame, and the incidence. And that's all we have to say today about the immune and allergic responses. As always, please let me know if you have any questions or concerns, and we will see you in class.